Welcome back. Today, we're putting on our clinical detective hats to crack the code on a very tricky topic: elevated troponin levels. In Part 10 of our Myocardial Infarction Coding Masterclass, we are tackling a major diagnostic crossroads. We need to figure out how to definitively separate non-ischemic myocardial injury from an acute MI. Let's get right into it. So, here's the million-dollar question. If you see an elevated troponin value in a patient's chart, does that automatically mean they're having a heart attack? Well, absolutely not. For the longest time, there was this kind of knee-jerk reaction in the medical field, right? You see high cardiac troponin, you automatically assume it's an MI. But as our understanding of cardiac biomarkers has evolved, our clinical definitions and our coding guidelines have totally shifted. We really have to separate this concept of injury from the concept of infarction. It all basically boils down to one word: ischemia. An MI absolutely, literally requires clinical or ECG evidence of acute ischemia. We're talking about ischemic chest pain, new ECG changes, or imaging that actually shows a loss of viable myocardium. Acute myocardial injury, on the flip side, it still features those elevated troponin levels, meaning, the heart cells are definitely stressed or dying, but it happens entirely without that overt acute ischemia. The tissue is getting injured, for sure, but not because of a sudden localized coronary blockage. So first things first, we've got to establish our baseline. How do we even know an injury is happening? Honestly, it just comes down to the math. Any cardiac troponin value that spikes over that 99th percentile upper reference limit, the URL, is our very first major clue that myocardial injury has occurred. That greater than 99th percentile threshold is our universal gold standard. If it crosses that line, boom, injury is present. But our job as coders and CDI specialists doesn't stop there. We've got to figure out the actual pattern of that injury. Now, I love looking at the troponin kinetics because it basically builds an if-then logic path for us. It's kind of like your ultimate coding cheat sheet straight from the clinical guidelines. Think of it like this. If you've got a troponin rise and fall, and acute ischemia is present, well, that's an acute MI. If you see that exact same dynamic rise and fall, but there is absolutely no acute ischemia, that right there is an acute myocardial injury. And finally, if that troponin level is elevated above the 99th percentile but just stays completely stable, again with zero ischemia, you're looking at chronic myocardial injury. Let's break those categories down just a little bit more. So if the troponin rises or falls with ischemia, we are automatically routing to acute MI. Like we talked about in earlier parts of this explainer, this is usually triggered by a couple of main things. You've got atherosclerosis combined with a thrombosis. Think plaque rupture, which is your classic type 1 MI. Or it could be a massive oxygen supply and demand imbalance, maybe from severe hypertension, which triggers a type 2 MI. The key takeaway? Both of these involve acute ischemia. However, if that troponin rise or fall happens, but you're not seeing any ischemic symptoms in the chart, then we're dealing with acute myocardial injury. The heart is definitely still taking acute damage, but it's coming from completely different systemic stressors. Common culprits here, things like acute heart failure exacerbations or inflammatory conditions like myocarditis. The cells are leaking troponin because they're essentially inflamed or failing under massive systemic pressure, not because an artery suddenly got blocked. And what if you're auditing the labs and you just see this stable, flat, but elevated troponin level day after day? Well, that's where your detective work points to chronic injury. This is not a sudden, acute event. Usually, this stable elevation is bubbling up from long-term underlying issues. We're talking structural heart disease or chronic kidney disease where the kidneys just aren't doing a good enough job clearing that baseline troponin out of the blood. Okay, so how do we actually translate all this incredible clinical science into our coding language? When your chart review confirms an injury without ischemia, whether it's acute or chronic, here is your target code: I5A, non-ischemic myocardial injury, non-traumatic. Honestly, adding this code to the ICD-10-CM manual was a massive game changer. It finally gave us a highly specific way to capture this exact clinical scenario so we don't end up incorrectly defaulting to an MI code. But wait, hold up. You can't just slap I5A on the claim by itself and call it a day. We need to look at the sequencing rules to see how this actually builds a complete clinical picture thanks to the code first mandate. The guidelines are super explicit here. I5A is not meant to be a standalone primary diagnosis if we know the underlying cause. So, step 1, pinpoint the underlying etiology. Step 2, apply the code first rule to that cause. And then step 3, sequence I5A as the secondary diagnosis. Because myocardial injury has such a wide spectrum, you absolutely have to sequence that underlying cause before reporting I5A. You've got to round up the usual suspects. Is the patient dealing with severe hypoxemia, hypotension, or maybe shock? Do they have underlying chronic kidney disease or heart failure? What about anemia or ventricular tachyarrhythmia? If one of these specific conditions is the root cause that's stressing the heart and causing that troponin leak, you code that condition first, and then you follow it up with I5A to show the resulting cardiac injury.
All right, let's talk about the real world for a second, because we all know things aren't always perfectly documented. As a CDI specialist or coder, what do you do if the chart shows a clearly elevated troponin, but the provider's notes on ischemia are just incredibly vague? Like, what if they just jot down troponin elevation or demand ischemia, but they never clearly link it to an MI, and they don't explicitly say it's a non-ischemic injury?
Well, you simply cannot guess. You must query the provider to definitively rule ischemia in or out, period. Your coding accuracy, your facility's data integrity, and honestly, your ability to defend an audit depend entirely on that binary clinical distinction. You've got to ask the physician directly, based on these elevated troponins, are we treating an acute MI with clinical ischemia, or is this a non-ischemic myocardial injury secondary to something else? Getting that crystal clear up front is going to save you from massive compliance headaches and denials down the road.
So to wrap all this up, just remember that elevated troponin is basically a biomarker signaling that the heart is crying out for help. It is entirely up to you to check those kinetics, hunt for ischemia, and apply the rules for code I5A correctly. Mastering these profiles doesn't just protect your revenue cycle, it makes sure your patient's true clinical narratives are actually captured. So think about it. How many claims in your facility right now might be defaulting to an MI just because nobody asked the physician for clarity? Keep digging into those charts, keep querying for the truth, and as always, decode healthcare with Harshal.